aware of this through PHS, except for a couple. It's just going to take a little extra time. When we look at medical terms, we look at musculoskeletal. The O, that vowel is connecting muscle and skeletal system. It gives shape, right? Without bones or muscles, we would be blob. And then everything vital is underneath the rib cage, so it protects it. And then we provide locomotion. We're able to move with our system. Along with the other bones that I've given you, add these in there if they're not in there. The orbit, the eye socket, sort of the orbit, is composed of really this bone right here with part of the maxilla and zygomatic. We'll learn at the end of school about facial fractures, and these bones fracture, and it's quite significant when they do. The zygomatic, or this cheekbone, right? The nasal bone, you have a small bone up there. Most of your nose is cartilage. And then the maxilla is the non-movable bone in the face, and then the mandible is a movable bone, obviously. People who fracture their mandible, they get their teeth wired together a lot to let that set. And there's problems with that as well. But do commit these bones to memory along with the other ones. We have an interesting cross-section here. I want you to keep this picture in mind for several reasons, because we'll keep coming back to it. We'll come back to it a lot. One is, let me give you sort of a walkthrough. Here's the spinal column. Here in part here, you can see the vertebra there, right? And then the spinal cord that comes up through this hole in the bottom of the skull called the foramen magnum. It's the weirdest name. I don't know why they would name a hole that, but I guess somebody, whoever found it, maybe that's their name. All right, but this hole. And then you have the brain stem that goes up from there. The problem with this hole is it's not big enough for the brain stem to come back down through. The brain stem developed here, okay, and that's important as we get into strokes and different things, head bleeds, because it puts pressure on that brain stem and pushes it back down through that hole, called brainstem herniation, and it's life-threatening. So that's one picture, what you have. And then we have the brainstem here that controls all the vegetative functions. The biggest thing that we're going to look at the brainstem within a week or two is respiration. The respiratory center is located on the brainstem. It's responsible for all of our the chemical part, a little part of our respiratory drive, and then the rest of the vegetative functions. Vegetative functions mean what we have to live, right? Brainstem is very important, but we focus primarily on the respiratory center. You have the small brain, or the cerebellum, right? There controls fine motor skills, and then the cerebrum that controls gross motor function, big motor function, right? And thought, memory, and then of course those dreaded sinuses. In Texas, you have these sinus cavities. When you get a sinus headache, this is where the pressure builds, right behind the eye, right? So you have this headache and this pressure right behind the eye. It's a sinus. Make sure you're taking sinus medicine for that, or right here on the side. Okay. We move over here, and this will be important in about 2 weeks. The airway. So we have the nasal airway. These parts right here are the turbinates, and they have a lot of blood flow that go through the turbinates, because part of the function of the nose, because adults are nose breathers. We breathe through our nose. Adults are not normally mouth breathers. Okay. Did y'all watch that? What was that they called it, mouth breathers? Stranger Things. right? That little girl called people mouth breathers. But anyhow, adults are normally nose breathers, and we breathe through our nose. And part of it, the function of it, is to warm the air. So as we breathe through, these turbinates warm the air, right? And then filter, warm and filter. So as it comes through, the turbinates warm it, and the nose hairs filter out all the dust and particles we have floating in the air. Hence, the burger. So the nasal airway connects through the nasopharynx, the O there, into the nasal. Having an old moment. And then the oral pharynx, right? You have the nasopharynx and the oral pharynx, and it connects sort of in the pharynx or the throat. Both of these airways connect with each other in the back of the throat, right? In the oral pharynx, and then we come down here, okay, and we have the epiglottis. And the function of the epiglottis is, as like right now, my epiglottis is open because I'm talking, right? But when we eat or swallow liquid, the epiglottis covers the glottic opening, which holds the vocal cords, so we don't aspirate. So we don't, you heard of swallowing, going down the wrong pipe. That is primarily because people talk and chew with their food, talk and chew at the same time. So they're talking and they're chewing and they swallow and the epiglottis is open. This is how, and we'll speak of this when we get to CPR. The food gets lodged right here because the epiglottis is open. All right? And then we have to do the Heimlich on a conscious person. Right? What about the tongue? What is the most common airway obstruction in an unconscious person? Right, tongue. The tongue, remember, it's connected. You can't swallow your tongue. That's a myth. It's connected by a bone there. When we get to Goldie, I'll show you the bone that's connected to. But what happens in an unconscious person, the tongue becomes flaccid and falls over the epiglottis and keeps it shut where the person can't breathe. And that's where you have to open their airway. It's a pretty simple maneuver. Have you guys heard of a head tilt chin lift in an atraumatic patient? Head tilt chin lift? Did y'all do CPR last year? Really? Okay. Well, this is just a trailer then. We'll get to what's called a head tilt chin lift, and that's how we manually open the airway. We lift the chin up and tilt the head back, and it mechanically pulls the tongue off the epiglottis. More to come later. Okay? But that's an interesting view there of this sort of cross-section because there's so much stuff there. And then here's a nice picture of the brain again, sort of a cross-section of it. We have the cerebrum, this big, which controls all of our gross motor functions and memory and thought process and everything else. And there's the brain stem, the cerebellum, and then the spinal cord sort of wrapped up in there. In October, we're going to UT Southwestern. You'll get to see this. You'll hold a brain in your hand and go, wow, that's pretty cool. It's pickled, but it's you'll be able to hold different organs, and you really get a good understanding of the anatomy once you do that. Once you look at it, go, yeah, I get this. I get the size of the heart, and I see a big heart, that's overstretched, and your sight is a sense, right? One of the, how many? 5, 6? What do we have? Sight, smell, taste, hearing, touch. Okay. In order for you to remember things in medicine, you use, I don't know about taste, but don't lick see if it has glucose in the urine, right? So, but smell definitely. You smell something like lower GI bleed, and boom, all that information comes rushing back to you. And we talked about, right? It's these things. That's why Goldie is so important, because the tactile, the touch, you remember these things as you use the senses as you go through trying to recall information. This is a good picture of the brain. Okay, this is really cool. If I can get my mouse going. Stand by.
Students think that the brain is sort of the consistency of a rubber ball, and that's because in the laboratories and teaching specimens we have formalin-fixed brains. However, if you're a trauma surgeon or a neurosurgeon, you realize that the brain is really very, very soft and much more vulnerable than the impression you get looking at the fixed brain. So I would like to show you a 1,400 gram brain that has just been removed from an autopsy, and we are fortunate enough to be able to show you what a normal, unfixed, recently deceased patient's brain would look like. This is the ventral surface of the brain, and what you see are the peel vessels, this nice blush with the clear leptomeninges and the vessels running in between the arachnoid and the pia. The cerebrospinal fluid has leaked out through the cisterns, and so the subarachnoid space is no longer visible unless I move the brain, but it's very, very soft. Notice, it's totally squishy. It's the consistency, it's much softer than most of the meat you would see in a market. So if I were to pinch this, in either way, I could easily damage this with my thumb. In fact, neurosurgeons, when they are doing surgery, often just evacuate with a vacuum or suck out parts of the brain. This string here has been placed around the basilar artery so it can be suspended in a bucket of formaldehyde in order to denature the protein and harden it. If we didn't, it would sit on the bottom of the bucket and the brain would become deformed, as you would see here, so that it would be compressed in this direction just from the weight of the brain. So that points out one of the purposes of the cerebrospinal fluid is to float the brain inside the calvarium and act as a cushion. The cerebellum is easily seen, the medulla, the pons. Here you can see the arachnoid spanning across the space here at the base of the brain. The optic nerves are very obvious, as are the olfactory nerves. Here are our temporal lobes, and here is the uncus on either side. The uncus, remember, is the most mesial part of the temporal lobe. The tentorium that fit in here has been removed, but we can see a slight groove right along here where the tentorium sat. So there is no evidence in this brain of any of the temporal lobe herniating medially over the edge of the tentorium. It's a beautiful specimen. Unfortunately, this cancer patient died of complications secondary to a cell transplant. Here you can see how soft and pliable the dura is, and we can look down between the hemispheres and see the corpus callosum. I can also see a bit of the anterior cerebral artery coming over the surface. So this is the interhemispheric fissure. And if I turn the brain around and we look at the occipital lobe, we can see the top of the cerebellum, And here there is a very small amount of blood that was actually seen on MRI that the patient had before death. If I let the cerebellum hang down a little bit, you can see the superior surface of the cerebellum. Turn it back around. So our very delicate and vulnerable brain, with its two vertebral arteries on the medulla, its basilar artery on the pons, it's branching to the posterior cerebral artery right here where you have the cerebral peduncle, and here we have the interspace. Here is the interpeduncular cistern, and we can see the two mammillary bodies. The pituitary gland stayed within the body, and here you can see the base of the brain with the optic nerve, the chiasm, and the tract. You can see here an impression, a depression just from where I was holding the brain. Just from holding it that small amount of time, the depression from my finger is clearly visible. Think how vulnerable the brain is, then think how narrow and small the spinal cord is, and what a devastating consequence just a quick subluxation of the vertebra or a herniation of the disc can cause to the delicate spinal cord, which is about the width of one of these gyri. These gyri are nice. There's no big space between them, but neither does it look particularly swollen for a patient of this age.
Pretty cool, huh? Now, what is a couple of things you noticed right away about the video?
The brain?
No, just in general. What's a couple of things? Thinking way too much. Yeah, you want that. It's pretty bloody. Unfortunately, we're not going to be able to hold a live brain, because unless you just get lucky. But because it'd be in formaldehyde, be hardened. What about the medical terminology? Right, in the anatomy of the brain. There was a lot, right? I mean, there's a lot of things that she was just sort of spitting out. Okay, how many? Is this a class with all the neurosurgeons in it? Everybody want to go neuro? A lot of them do. Okay, welcome to your world. You will. That's your specialty. You have to just spit that out. You know that, like you know your name, right? And a lot of those terms you will know by the end of this year, because we'll talk about those, the pons, the medulla. We'll talk about those things coming up rather quickly. Anyhow, so a lot of terms, right? And that nurses. How many of you guys want to be nurses? Anatomy, Physiology 1. You will know the majority of those because you know the anatomy of the brain, right? That means the whole brain. So all those things in there, at some point in time, you have to memorize. Right? And then sometimes you let them go for the majority. Unless you're going into neuro, then you would need to hang on to that information. Right? So there's a lot. We're not even going to cover most of that. But there's a lot of anatomy that we're just not going to cover. We're going to cover a great deal, but as you can see, there's a lot more to go, right? In those medical students with this professor, the expectation would be that they would know that. So she would point to if you guys were medical students, and I pointed to a location on that brain, the expectation would be that you would know that. On Monday morning, Tuesday morning after a long weekend, you would know that. So it's a very reactive type of atmosphere, and the accountability is high. Anyway, let's move on because we're just looking at the pieces and parts right now. So you have the spinal column, you have the cervical. Is it vertebrae? Vertebra. How would you pronounce that? Vertebrae? Okay. The vertebrae, so the cervical vertebrae, the thoracic, lumbar, sacrum, and coccyx, you will need to know the different sections of the spinal column, and here on this one, how many vertebrae in each section, okay? But let's look at bones for a second. There's no way to get around without flashing you, but we'll be good with it, okay? Woo. Yes, that's going on. Glad you didn't poo. So you look at the cervical vertebrae. One thing that we will learn fairly close is to hold C-spine. The C-spine is the cervical spine. Someone in a car wreck, these fracture not easily, but they're the most ones that fracture because they're the smallest in size. And so when we hold C-spine, we would just hold the patient's head still because we talk with our heads, right? And we don't want them. So when we're asking the patient questions, we want their head still. So holding C-spine, you wouldn't pull or push, you just hold it still. So the patient, you restrict the patient's movement on the head. But you notice these are smaller in size. Right? There's 7 of them. Up here top, you have the axis and the altus and the axis. I can never remember the difference. C1 and C2, okay? C1 and C2 allow us to move our heads up and down and side to side. Okay? Someone that fractured this, it used to be called a hangman's fracture because back in the Western days, in some countries still, they hang people and they get the big knot, right? The hangman's knot. Okay, the purpose of that is to fracture C1 and C2. Now it's probably more commonly referred to as the Superman fracture. You guys too young to remember Christopher Reeve? Superman? No? No? Okay. Anyways, Christopher Reeve he was an actor and he played Superman. Well, he went head first over. He was doing the things with the horse jumps and stuff, and he went head over the horse and he fractured C1 and C2. If there was a medical standby there, he would probably be just like everybody else that fractures C1 and C2. He would be deceased because a fracture up there that involves the spinal cord it instantly stops your breathing and you're not able to move any of the extremities. Right? So now we call it a Superman fracture. We'll get into that when we talk about trauma later down the road, okay? So you have the thoracic. These are bigger, thicker, and they don't fracture as easy. These are bones, right? So any part of this could fracture. The process on here, the body, Tony, I'll get it out in a minute. Tony Romo fracture. He fractured, get ready. He fractured the body of this vertebra, one of these. So that was his fracture. I think, best guess. And then you have the lumbar, which is the lower back, okay? And then the sacrum and the coccyx, which are fused together. The coccyx, this little tailbone here, it's in a very unusual fracture with somebody. People up north walk around on ice a lot of times. They have a tendency to fracture that because they slip, and it's not funny, but it's funny. Okay, they slip and they come right back down on their bottom, right? Well, they fracture this coccyx, and you can tell because those are the guys carrying the little inner tube around on that they have to sit on because you can't sit down. It's very painful to sit down. Either that or they have hemorrhoids. One of the two, unless you ask them. You can't. People have big old hemorrhoids. They can't sit down either. It's too uncomfortable for them. But when we have more time, I'll tell you my hemorrhoid story. Okay, I almost passed out. But anyhow, these are fused together. There's just nothing you can do. You can't like put a butt cast on, you know. I mean, so it just has to heal on its own. and it takes time. So you have the different vertebrae. I'm going to pronouncing that right. In the different sections. So commit that to memory. The different sections and the numbers as well. Okay, those are good test questions. And then you have the skeletal system, or the bones. And we'll go through the bones a little bit later, but you have the list, right? And so I want you to start committing that. Still, you should have already started committing those bones to memory on the ones that, or recall the ones that you not sure of. But we'll go down through the skeleton in a little while. I just wanted to sort of give a quick overview of it. You have irregular bones, like flat bones, short bones, and long bones. The longest, strongest bone in the body is what? Femur. If it wasn't so morbid, it would make actually a pretty good club for your protection. Quite strong. Ribs, because of the curvature of the ribs and these, the flatness of the scapula or the shoulder blade, they're very hard to fracture. And so these ribs are quite hard. What happens most of the time, people get soft tissue injury, these intercostal muscles here. When people have chest injuries, that's a lot of times, it's actually quite hard to fracture ribs. And then joints, you have hinge joints and ball joints, and this would be a knee. So tendons connect muscle to bone, and ligaments connect bone to bone. So this is where you get, like with a bunch of the sports players that have injury to their knees, like an ACL. This would be anterior, right? I mean, I don't really know the names of all the ligaments, and I don't expect you to. I don't really care that much. But this would be the medial one, correct? And the lateral. So the MCL would be this one, correct? Medial, whatever the rest of it, the name. The L is ligament. Not sure what this C stands for. Okay, but anterior, lateral. So you have these ligaments. The ligaments hold bone to bone, tendons, muscle to bone. Tendinitis. All right, so you get tendinitis. Have you ever had tennis elbow?
Oh, yeah.
Where it hurts right here? Little tendinitis. It takes a while for that to heal up, right? So you have to sort of go through a little therapy trying to heal that tendinitis. And the golfer's elbow is the same way. I have it right now. Little tendinitis right there. Just depends on what sport you're in, what they call it. It's the same ligament that's inflamed. Itis means inflammation, correct? And then you have a ball and socket and a hinge joint. When we get there, we'll talk about a fractured hip. Everybody's heard of that? Someone breaking their hip, elderly falling and breaking their hip. It's devastating because it stops their locomotion, and it's very, very painful from what I've seen for them to rehab. You'll see that in the hospital. They'll walk like, they'll creep along and like this, walking with physical therapy because it's so painful to rehab that hip. Where the fracture is usually in the neck. This is the femur, so this neck would be called what? Well, it's not a tendon, it's a part of the bone. It's part of there is a tendon there. The femoral neck, right? Neck of the femur, whatever you want to call it. The head, femoral head. This has a sort of strange name, the acetabular. Don't worry about spelling that. I'd never hold you responsible. I can just barely say it. But that's where this joint sort of articulates together. So a lot of times the fractured hip is here in the neck, okay, or actually a proximal femur fracture. So the fracture may be here. If it's fractured up in here, that would technically be a pelvis fracture. Pelvic fracture, a small pelvic fracture. So it just depends on where the bone is fractured. And then of course the hinge on the elbow and on the knee as well. Questions there? Everybody good? All right. 5 more minutes, we'll take a break, okay? Where's there? Muscles. 3 types of muscles: skeletal, cardiac, and smooth. All right? Voluntary or skeletal muscles, the same thing. So you have a voluntary muscle or skeletal muscle. Me holding this remote, I'm using voluntary muscles. Walking, I'm using voluntary muscles. The brain is sending signals for me to grip this and to move, right? So it's complicated. There's other systems that have to work. If my brain wasn't functioning and telling my hand to grip, then I wouldn't be able to hold this remote. Like someone having a stroke, they may have paralysis, hemiparalysis, right, on one side, and so they may have paralysis here where that part of the brain is not functioning because of a stroke. Right? Y'all savvy stroke? Y'all talked about stroke a little bit? Okay. So, but it attaches to bones. It makes us form. This is where we get the bulk of it. It's under conscious control. I have control over voluntary or skeletal muscle. Then you have involuntary or smooth muscle that's autonomic. I don't have any control over it. The bronchioles, smooth muscle. The gut has smooth muscle in it. I don't have to tell my body to digest or my bronchioles to expand, right, to breathe. It's under smooth control. I mean, it's smooth muscle and it's involuntary. I have no control over it. And what about the diaphragm? Smooth or skeletal? Can it be skeletal? Why?
If you need to yell, you can use your diaphragm to yell louder. That's what I think.
Okay, never thought of that one. All right. Can you stop your diaphragm from moving? Everybody hold their breath.
So it moves down when the lungs breathe in, doesn't it?
Right, but we're trying to determine if it's smooth or skeletal right now. So everybody hold their breath. Can everybody hold their breath for a certain period of time, right? And then what happens? The body's going to take over. You're going to breathe. It's like the kid's like, give me that bowl of ice cream, that bowl of Bluebell, I'm going to hold my breath. Go ahead. 2 minutes or less than 2 minutes, you either breathe or you pass out and then the body take over either way. Right? So go ahead and hold your breath. All right? So what does that make the diaphragm? And skeletals, both. Because you have some control over the diaphragm. Like you said, singing, you use in conjunction with those. When you yell, it's actually in conjunction with your abdominal muscles. You pull your abdominal muscles in somewhat. But so the diaphragm is both smooth and skeletal muscle. The way that we see this is here. We don't do it here, but in A&P 1, you look at slides and you have to identify these particular types of cells. You identify smooth muscle and see how smooth it is, or the skeletal muscle, and then smooth muscle. It just has a different look, and then cardiac muscle. Cardiac muscle on its own. Whoops. Don't have a little seizure. Okay. But cardiac muscle on its own, right? It's a specialized muscle to itself. you guys will know the heart so well before the end of the year, the cardiac muscle will just become second nature to you. You know so much stuff about it. The reason being is that we learn so much about the heart and the lungs, the circulatory system and the respiratory system, is that all the medical emergencies that we're talking about affect those, the heart and lungs. Not all of them affect the brain and the kidneys, and so we won't learn as much about those as we will about the heart and lungs. It's really important to know that. All right. Questions there? Is everybody good? All right, let's take our break.